shall now go on to our next speaker, Dr. Akshay Goyal, who practices at Sankalp Hospital at Ambikapur, Surguja, right? And he
I'm
presenting a very
Chhattisgarh.
Chhattisgarh, and he
Yes,
will
ma'am.
be presenting a very interesting case. Let's hear from him. On to you.
Thank you, ma'am. Thank you for giving me this opportunity today. So I would like to show my videos. I'll start sharing the screen. So we have this 25-year-old female. This video was recorded about 3 years ago, and as you can see in this patient, we have an Argentinian flag sign. So I proceeded with a gentle hydrodissection in this case, and the entire case was completed using IA mode in very low parameters. I was lucky enough to have a soft nucleus where I could manage the entire case just in IA mode. And while the whole procedure, I made sure that the AC doesn't collapse. So I kept injecting viscoelastic from the side port the whole time while the case was going on. And I proceeded by completing the whole case in IA mode. And after that, the IOL was also implanted in the bag, and viscoelastic was removed by very low parameters under low vacuum. So coming to this, but then I realized that I need to go back and ensure that these cases do not repeat. So I came up with this kind of a modified technique. In this, I take my cystitome with visco, and I just do a central stab kind of an incision in the center of the capsule. So the entire liquefied cortex starts coming out, and I start injecting viscoelastic as soon as possible after that. Due to that, the tenting of the anterior capsule doesn't happen, and the positive pressure from the top causes all the liquefied cortex also to leak out from the small opening that I've created. After that, I gently nudge the CCC and ensure that very fine movements are done to keep all things under control, continuously injecting visco the whole time. And then I start initiating the rexis in a semicircular manner to have a better control. As soon as any kind of liquefied cortex comes into the view, I inject visco immediately, and the liquefied cortex, it starts leaking out from the side port. By very gentle and fine movements, I continue with the rexis, and I usually aim for a 4.5 to 5 rexis in a case like this, and ensuring that slowly and giving adequate time, injecting visco again and again. Now, as you can see in this case, I have managed a fairly circular rexis. Similarly, I'll show another case. In this, again, I've first gone in, injected visco to flatten the anterior capsule, made a central puncture. You could see the liquefied cortex. Again, I've injected more visco, kept the anterior capsule flat, slowly, gently nudged the anterior capsule into a semicircular way, trying for a 5 mm rexis, injecting visco again and again. At such points, we have to be very careful with the rexis, ensuring that the vectors that come into play while doing the CCC have to be well controlled. The shearing and the tearing forces have to be managed, and the direction of the pull that we do has to be controlled. By injecting visco again and again, it is ensured that the anterior capsule stays flat. And as we know that the tenting of the anterior capsule is the one that causes the running away of the rexis. Again, in this case, we've managed a 5 mm rexis, and the case was completed successfully. Thank you.
Thank you. Thank you, Dr. Akshay. Many challenging cases you've managed. And I think when it comes to intumescent cataract, uh, many people have evolved different techniques. There are some who try to make it a little, not have a linear cut, inverted C kind of thing, so that that doesn't extend. And some people believe in making a very small rexis and then enlarging it. And you prefer to use a viscoelastic to flatten the anterior chamber. Essentially, there are different ways of skinning the cat, but um, And I suppose,
I tried using the double Rexis technique, ma'am, but I felt that while initiating the Rexis, if we do not add viscoelastic adequately, it can just run away anyways. So when we are doing that effort of making a small Rexis, why not just inject some visco and get a Rexis of a decent size in the first place?
yes, Dr. Sanjay Chaudhary.
Well, like you said, that so many ways which have been put forward to manage this excess from running out. The problem is that in many cases, when we almost think that a technique is good, it may be one of those cases where the excess was not likely to run out.
Yeah.
So you can really not know whether any particular technique has become 100% successful. But yes, we do know that this happens in those white turgid cataracts where there's a lot of vacuolation over and under the nucleus. And the moment you give a puncture in the anterior capsule, a little milk comes out, and the pressure under the nucleus pushes the nucleus upwards against the anterior capsule, and that's what makes it run out. So decompression of the bag has to be done very carefully. That is the main thing. How you decompress is everybody else's choice.
The other thing is, which kind of capsule would run away faster? Would it be a young elastic capsule which runs away faster, or I, which is there's a lot of intralenticular pressure in the capsular bag? Which would you think has greater chances of running away?
Ma'am, more intralenticular pressure would run away, I feel. And I give preoperative acetazolamide as well to kind of counteract that.
See,
Young patients, I put some more trypan blue.
No, Tiffany blue.
just a small thing. Actually,
Yeah.
intralenticular pressure is high in all these intumescent cataracts, but there are basically two different kinds. One where there is fluid and one there is no fluid, but the
Yeah.
cortical fibers are swollen. So
Yeah.
there you will not get fluid, and these are the cataracts which are more likely to run off.
Run away.
Where there is fluid, it can easily, you can aspirate it like you put in
Yeah.
visco, then the fluid will come out. But you
Yeah.
saw the last case where there was no fluid and
Yeah.
you were lucky that it didn't run out. In these cases, you need to actually decompress, and these are the cases where either you do a small initially,
Yes.
decompress and then cut and then open, make one more, or you do a spiral if you feel it's under control. These are
And
just
you should also do multiple evacuation from multiple points so that the capsule actually becomes a bit
Dr. Jain,
concave.
sir wants to say something.
Yeah. So like Naga is saying, once you have a fluid, it's
Yeah.
much easier to do. You can
Yeah.
always aspirate it
Yeah.
and also give a nudge to the nucleus posteriorly. Like
Yeah.
Sanjay was saying, we have
Yeah.
to break the nucleocapsular block at the equator
Yeah.
because that is the one which pushes the nucleus anteriorly, the fluid trapped behind the nucleus. And the most important way to know which axis will run off is to do a OCT. The more spherical the crystalline lens is, because whenever there is a increase in intralenticular pressure, there is no way to know how much is the pressure inside, because in all these cases intraocular pressure is normal, so only the intralenticular pressure is high, and once there is no fluid cortex, there is nothing to egress, so that are the cases which runs off. And if on OCT you see a globular type of thing, here the zonules are stretched to the maximum. So once the lens becomes sort of globular instead of biconvex, the zonules are at most stretch. And once you give a neck, there is a relaxation, there is a pulling of the capsule by the zonules at that time. So the idea is to compensate the or equalize the pressure inside the chamber and intralenticular pressure by a high viscosity viscoelastic which doesn't flow, a cohesive one like a Helon GV or Helon GV5, Helon 5, right? And that is the only way to do it. OCT, there is a very good paper by Tityal. Even we have shown these OCT picture. There are four grades on OCT of this. The most globular thing of the crystalline lens, these are the cases which are running out. That's why even after aspirating the fluid anteriorly, you push the nucleus at the edge to break the nucleocapsular block and to release the fluid which is behind the nucleus. So that we have to understand the physics of this thing. That's the only comment I want to do. Because we have published, you can read our paper. We have done more than 100 cases without any capsule running away. It's published in IGO. First, we published the technique, then we published the series of cases. Though even Rajendra Prasad has published this sewing needle technique, but that is only a technique. He has not shown any series of cases. We have more than 100 cases, 121 cases, which are published in literature. Yeah.
Thank you.
That's very nice, the discussion which followed. So we shall now go on to thanks Dr. Akshay. We'll now go on to